Hey, everybody, welcome back to another episode of Confessions of a Male Gynecologist. And I think this episode, well, I probably say this with every episode, but this episode is on a really currently hot, juicy, amazing topic. And anybody that's watched the news for more than 5 minutes knows about these medications called GLP-1 agonists, semaglutide, Wegovy, Ozempic, Mounjaro. There's a whole bunch of them now. But anybody that knows anything about weight loss, has heard about weight loss, is up at midnight searching weight loss, has heard about these medications. They were unheard of, not unutilized, but unheard of for years and years and years. And now they're in the spotlight because celebrities have actually kind of brought it to the forefront, which is what celebrities do. They make us think that we need to lose weight and we're horrible people and we're not as beautiful as they are. And well, they're not as beautiful as I am. That's the way I look at it on the inside. But these medications really just skyrocketed to popularity to the point where in the last few months, this is February of 2023, probably for the last 4 or 5 months, there have been shortages of certain dosages of these medications because they have been utilized so much for weight loss indications. Now, they've been used for type 2 diabetes, and type 2 diabetes is that diabetic who gets the diabetes in their older age. So type 1 diabetics, they are like one of my cousins diagnosed with it usually as children, and that's the pancreas's inability to make enough insulin to control blood sugars and can be obviously life-threatening. People that have type 2 diabetes are actually more insulin resistant, meaning their pancreas makes insulin, may not make enough, but it makes insulin that isn't working as well, primarily because they've gained enough weight and they've become obese by modern definitions, and they aren't using their insulin very well. And so obviously their body has to try and make more insulin, more inflammation, more weight gain, the whole 9 yards. So basically, let's put this in a nutshell. It became trendy. And the problem wasn't that it was trendy, because I'm going to tell you what, this stuff works. And it works really well, and it can be life-changing for many, many people. Now, I'm not saying that that doesn't come without side effects or risks or anything else. I'm just saying, on the face, this stuff works. And I've used it in my clinic. I follow an amazing endocrinologist on the internet, on Instagram, New York Endocrinology, at New York Endocrinology, and I am pining to get her on the podcast. Hopefully, she'll be on soon. But she's the resident expert, and I follow her, and I like her, and I'll tell you why. Because she's non-judgmental. She's non-threatened by all these clinics that are popping up. She's not threatened by people like me that might be prescribing it. She's the expert. She knows she's the expert, and she really gives balanced, smart wisdom on these medications, and she does it every day, and she does it in an amazing manner. There's a lot of endocrinologists out there that like bashing the drug, but it's not the drug. It's the people that are using it or prescribing it, and they're just doing it wantonly. They're not being selective with who they pick. So let's back up a little bit. Let's get a little history on these medications. Researchers have been looking for insulin stimulating medications for more than 100 years. And in the 1960s, it was proven that the gastrointestinal tract releases insulinotropic factors that affect glucose intake. And they called these medications incretins, which is what semaglutide is. The first significant factor that they ended up isolating was duodenal glucose dependent insulinotropic polypeptide, or what we call GIP. And it turned out, though, that it didn't stimulate insulin secretion in patients with type 2 diabetes, but they did find that it worked to a certain degree. And so the story began. So the concept of incretins and these medications has been around for 60 years at this point. What they found was these glucagon-like peptides is what these are called. They truncated it to GLP-1, was isolated from the gut And it was found to both stimulate insulin secretion and inhibit something called glucagon. And glucagon is stored in your liver, and our glycogen, is stored in your liver. Glucagon is a hormone that helps with secretion, and helps with all things glucose. Obviously, the truncated gluc that's in there. The peptide itself also inhibited appetite and food intake, so it curbs the appetite. And unlike its predecessor, GIP, it basically preserved its effects in patients with type 2 diabetics and was found to have powerful anti-diabetic effects in clinical studies. However, it had a really short half-life, so they weren't using it a whole lot. And the half-life just means the amount of time that the drug remains active in your body. So we fast forward a little bit. We have these drugs. They've been isolated early on. And what's really fascinating about semaglutide, at least this is my research, it basically kind of came from the Gila monster. And any of you that live in the desert, I spent 12 years living in Tucson, Arizona, and it will always have my heart for multiple reasons. But it was discovered that the Gila monster contained hormones that can regulate blood sugar in their venom. And so a scientist named Daniel Drucker, who's an endocrinologist at the University of Toronto at the time, had dedicated his career and his universe basically around hormones and what can regulate appetite. So out of curiosity, Drucker got a lizard from a zoo in Utah, and had it shipped to his lab, and began experiments. Now, Gila monsters obviously have deadly venom, so it's really fascinating to me where we find medications and where they come from and how we even figure this stuff out. 10 years later, this was in 1995, he started this experiment. 10 years later, he had a synthetic version of the hormone that was in the venom, and it became a medication to treat type 2 diabetes, and it was known as the GLP-1 or glucagon-like peptide receptor agonist, meaning it stimulates the GLP-1 receptor. And this actually started the whole cascade of medicine looking at different venoms for medications. So semaglutide's been around for a long, long time. Now, after doctors noticed in mice that the drug that was used, they eventually started losing weight, the mice, and then they started using it in humans. It was then used for obesity, and it was approved by the FDA in 2021, so not that long ago, for obesity. Now, people think that these drugs are new, and they're not. And the whole purpose of this intro piece was to just let you know that these drugs are not new. They've been around for a long, long time. And if we think about the other things that are being used currently for weight loss, from jaw wiring to laxatives to vagotomies, where we cut the vagus nerve, lap band operations, gastric bypass, fen-phen, all these other miracle drugs, the green coffee beans, people and women especially have been spending billions and billions of dollars over the decades trying to lose weight and trying to effectively lose weight. There have been other medications out there, like I mentioned, fen-phen, which ultimately the Pondamin part of the fen-phen actually started causing heart disease. The phentermine is still used. It's purely speed. It's in the same categories with Adderall and Vyvanse and those, because it curbs your appetite. Although obviously not sustainable, because once you stop using them, your appetite comes back. You'll start eating, which is a criticism of the GLP-1s as well. But we'll talk about that in a minute. So let's just say weight loss is a multi-billion-dollar company in and of itself. But the question is, if you're somebody that struggles with obesity, high blood pressure, metabolic syndrome, heart disease, cancer, inflammation, joint disease, I mean, if you had a medication that could help this individual lose 15 to 20% of their body weight in about 6 to 12 months, would it be worth the investment? And I think the judgment that's being thrown around right now is pretty ridiculous, because most of the people that are judging are being really critical of individuals who have an issue that they don't want. Nobody wants to be morbidly obese. Nobody wants the side effects. And the women that I talk to on a daily basis, they want to be here for their kids. They want to be healthy so they can run around in the park and do the things. And for some folks that are even heavier, they may have problems doing daily things, like even tying their own shoes or going to the store. And yeah, sure, we criticize them. Oh, you should pay for 2 seats on the plane and blah, blah, blah. That's coming from a different place. And I don't want to go there today. I don't want to be that judgmental person. I want to talk about what can happen with this medication and why it's so amazing and why we should consider using it as providers in a safe and productive way. So, a lot of doctors that are used to treating patients point out, now this medication isn't going to take a person who's, say, 280 pounds and make them 130 pounds. That's just not the way that works. Now, that person could lose 50 pounds. So what's the criticism? Well, the criticism is about 85% of patients that have gone on these medications, if they go off cold turkey, gain the weight back. And that's pretty common with a lot of these medications, with not just semaglutide, but with fen and other medicines. And the reason is, as we know, weight loss is not one facet. It's a multifaceted process. And the mind body part of that is humongous. Yeah, you can curb somebody's appetite, but if they don't make the changes in their life, then they're not going to probably keep the weight off. And so, if we're going to use semaglutide as a weight loss medication, you have to incorporate it with other things: health coaching, lab work, possibly a supplement program, a great nutritionist, a trainer. You really want to do this from multiple angles. The success rates would be much, much higher. Now, I don't have a study to prove that, but it just makes more sense to me that if you spend more time on all the other angles, you're going to have a more successful program. So, that being said, there are problems. The clinical trials showed that the medications help people lose about 15 to 20% of their body weight. I think Ozempic and Wegovy were 15%. Mounjaro was closer to 20%. The most common side effects with these medications: nausea, diarrhea, constipation. Most of them are short-lived. Gastroesophageal reflux, because the gut transit time slows down, so you can have more acid in your stomach. Now, if you're somebody that has a lot of vomiting, that's not normal. These drugs should not cause a lot of vomiting. And if they are, it's because the dosages were increased too rapidly. The way that these medications are structured is you start low, and then every month you increase the dose. So let's take, for instance, the drug Mounjaro, which is the one I'm more familiar with. There are multiple doses: 2.5 milligrams, 5, 7.5, 10, 12.5. And every month you go up until you get to the maximum dose. The other thing is, people that are moved up too quickly, and that's what's happening right now, is because, like, say for Mounjaro, the 5 milligram dose and the 10 milligram dose are not rightly available right now. They're having shortages because of the usage. And so some people might be moved from 2.5 to 7.5, and they may experience vomiting because it's just too much too quickly. So the thing about it is, you have to do things the right way as a physician. Now, I talked about the mindset shifts. Basically, what we know from general studies is that only about 1% of eligible patients who are using FDA approved medications for obesity, and the same for bariatric surgery, can drive things into remission: type 2 diabetes and or weight loss. And it's because it's the same analogy. If someone walks into your office with heart disease, say, and you as a physician want to treat it, you're going to like not just give them a medicine. Well, I shouldn't say that because it happens a lot. You shouldn't just give them medicine. You should also ask them, what are you eating? How long did it take you to gain all this weight? What's your family history? We want to dive into the patient's background and really know them a lot better and then work with them. Yeah, I can give you a blood pressure medication, but if I don't talk to you in depth, then why would we even be starting the medication? Because it's not going to, it might fix the blood pressure, but we're not fixing the problem. So that being said, if someone comes into my office with known heart disease and I don't treat it, that's malpractice. But if someone walks into my office and they have a BMI of over 30 and they're overweight and I don't treat it, that's like a Wednesday, right? That we don't get sued for that. We don't get in trouble for that. We just say that they're overweight. And what's interesting to me is that we also don't blame people for their high blood pressure usually, or we don't blame them for cancer, but we judge people who are overweight. We make assumptions that they're not trying, that they eat too much, that they don't exercise. And I don't think that that's necessarily a stretch. However, you can do a lot of the right things and still gain weight. You can have issues that are some things you can't control. Now, I know that might maybe come off as like snowflakey and that people might get mad at me and say, oh, come on, Tizone, you know they're eating their French fries somewhere. And maybe that's true in some cases, but I'm just saying it's not true in all the cases. But we need to have a mindset shift, not just in the patients, but we need to have a mindset shift in the providers. And this needs to be a multidisciplinary approach, meaning I, as a gynecologist, if I want to put someone on one of these medications, I should include a nutritionist. I should include a health coach, maybe bring in some supplements, give them a means of eating, give them a means of exercising. Don't just prescribe the medication and then say, see you later, alligator, and have them come in. And this is the problem that I have with the way that we do things in this country. The opportunism around this medication disgusts me in the sense that there are now these websites, they have popped up like freaking cancer everywhere on the internet. $200 a month, you know, and some of them are okay. They give a coaching program and whatnot, so it's not all bad. But they're part of the reason why the medications are in shortage. I signed up for one because I wanted to see how they worked. They told me I needed to have a visit with their provider. I never had the visit, and then I just got the medications. And then they also sent me metformin, which I didn't even ask for. Wasn't even part of the conversation. So I got two medicines that are pretty powerful that have side effects and never even spoke to a doctor. So my point being is, if you want to go on these medications, I would use a known provider. Don't use these anonymous websites where you really aren't getting the hand holding and the other parts. You're getting some sort of ubiquitous person you've never met. I like to work with my patients as individuals, and I do try to get them the medication. I'm even looking at compounded semaglutide now because the medicines are so hard to get. They're about $1,100 a month, and it can be compounded sometimes for $200 a month. And I really think that the benefits at this point are so huge, they outweigh the risk. So let me talk about a couple of the different medications, specifically the semaglutides, Ozempic and Wegovy. Wegovy is the brand name of semaglutide that was the only one licensed to be used as a weight loss medication by the manufacturer. Wegovy is a weekly weight loss injection that the patients administer at home in a measured dosage with an injection pen. So actually, it's really easy to give. You just take the cap off, hold it up against your abdomen, you unlock it, and you push the button. And you just hold it there for 5 to 10 seconds, and it distributes the medication. Suitable patients for Wegovy include people with a BMI over 30 or more, obviously, and those with a BMI of 27 or more who are at risk of developing weight-related medications like type 2 diabetes, hypertension, heart disease. You need to obviously see somebody qualified, like I just mentioned. You want to talk to an actual provider, and you increase the dosage over time. And the reason you want to have somebody that you can reach is because what I've seen with a lot of these fly-by-night websites is you might be having nausea and vomiting or some sort of a complication, and you can't get anybody to return your call for a week. And that's just unacceptable to me, especially with a brand new medication. Ozempic basically is the brand name that's manufactured by Novo Nordisk, and it is specially formulated or was made for type 2 diabetes. So Wegovy was marketed FDA for weight loss, Ozempic for type 2 diabetes. Started going through clinical trials in 2015, approved in the USA as a type 2 diabetic medication in 2017, and it wasn't used even in Europe, I don't think, until 2019. There are some other medications that branched off of Ozempic that were longer acting. A medication called liraglutide, which is slightly different, and that's the active ingredient in the two medications, Victoza and Saxenda. Victoza actually is a once daily injection that was used for the same thing as Ozempic, meaning that it was used for type 2 diabetes. And they just thought it would be more convenient. But most people that I've seen that used to be on Victoza are moving over to Ozempic. And then there's Rybelsus. Rybelsus is the brand name for semaglutide, but it's in a tablet form. Makes it much different, obviously, than Wegovy and Ozempic. Rybelsus is a type 2 diabetes treatment that works in the same way as the other semaglutide formulas do, but it's made in a tablet form. And I think it was specifically formulated for people that didn't like the idea of needles and or can't use the pen properly. They just have certain problems where they just can't use it the right way. So let's talk real quick about how these medications are made. Obviously, like I talked about, a company like Novo Nordisk, they spend billions of dollars or millions of dollars, hundreds of millions on getting a patent. They patent the medication or they patent the delivery system, and then they charge gobs of money, as we're seeing. And that's their right. Might not be ethical per se, but it's their right. They own the patent. They've spent a lot of money and they need to make their money back. When there became a shortage and it became very popular, we started seeing some compounding pharmacies in this country making semaglutide. And they can't technically make semaglutide because it's a patented product. So they have to add something to it to make it a little bit different. So they're not running amok of patent laws. So a lot of them are including NAD, vitamin B12, whatever it is their formula is, so that they can mix it. Now, you all know that I love compounding pharmacies. I think that compounding pharmacies are literally the shit. They allow us to personalize medications. They have the ability to be local. So they're giving jobs to local pharmacists and employees, farm techs and whatnot. And they don't have the same issues that I have with big pharmacy. Now, I'm not a big pharmacy hater, but as you see, they jack the price up fivefold. Now, we have to give them their props because without the big pharmacy, these drugs may never have made it to market in the first place. So it's a double-edged sword. The compounding pharmacies, the only problem that I'm looking through right now is, one, are they making the medication in a way that is safe? Are they making the medication in a way that's reproducible and gives you the same results? Because the last thing I want to do is give somebody a medicine that's not going to work because it's being made and it's not being made to the same standards. Now, there are a lot of physicians out there that hate compounding pharmacies and they won't even give hormones because of that very problem. I don't feel that because I have been using compounded hormones for 15 years and I see the same results and I can document on blood testing that they get the same results. So I'm a truster in compounding pharmacies. I love compounding pharmacies and I trust them. And you really want to work with a doctor and a compounding pharmacy that you also trust. So my point being is these drugs are becoming more available and they work really, really well. So here's my conclusion. This is just kind of a shorter episode because this is a very timely subject. And I wanted to go on the record saying that I do prescribe these medications. What I've been struggling with of late is that I can't get them for patients simply because, one, they're either not available, or two, they're so expensive, most individuals can't afford the price because we're looking at probably $1,100 a month. The compounding pharmacies are combating that. I don't know how much longer they can do it if they get in trouble or whatnot, but currently you're probably looking at a couple $100. Plus, you got to see a doctor to do that. But here's the thing. If I told you spending even $6,000, if you were to spend $6,000 and I could get you to lose 20% of your body weight, would you do it in 6 to 12 months? I couldn't guarantee it, but I'll tell you what, from what I've seen, it's pretty common to see that. Would you do it? I think most people would, because it's an investment in your health. It's an investment in you. And it's about damn time that we stop giving our money to the insurance companies for things that we should be able to prevent, right? And we have a medication here that can make you lose 20% of your body weight. And for somebody like me, when I started my weight loss journey, I was 218 pounds. For me, that would be like 40 pounds. I'd be 178, which is something that I haven't weighed since I was in the military. I didn't have high blood pressure. I didn't have, joint pain. I slept better at night. Would I pay $6,000 for that? Well, yeah, it's easy for me to say as a physician, but a lot of people they might take out loans to have that feeling. And I think it's worth it. Here's the problem. You spend that money, and then a year or two later, you gain the weight back. And here's my analogy. Let's say you're really strong and you're trying to fit a square peg through a round hole, and you get it in there. You got it. You're smushing it. You're pushing as hard as you can. And then you take the pressure off, and that block shoots out and goes back up against the wall and makes a hole in the wall. That's what it's like if you use these medications and you don't make the mind shifts. You don't make the nutrition exercise shifts, and you don't change yourself. But if you're trying to fit a square peg through a round hole and you get it in, and then you just use a little tapping, tap, 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 that block won't shoot back out. It'll probably either keep it where it is, or maybe if the changes you make are substantial and you have a lot more weight to lose, it might make it go all the way in. That's the exercise. That's the nutrition. That's the coaching. That's the supplementing. That's the permanent change. That's where I think we lose the battle with any kind of weight loss programs. So I just wanted to bring up something that I have been going through my own change and my own adventure, if you will, since about, 6 months ago, 5 months ago. When I was in the military, as I just mentioned, I think I weighed like 175. I was jogging 4 miles a day, had to do it. They were making me do it. I hate jogging. I was lifting weights. I was probably in the best shape of my life. And, you get out of the military, you have more kids, you get busy, you get in your job, you're trying to prove yourself, you're working crazy hours. Sorry, I had to take a drink there. You start gaining weight back. I hit like 190. And I remember thinking, well, 190, that's not great. My clothes were fitting a little different. But I was like, well, I'll just watch what I'm eating. I'll do a little keto, whatever. And then I hit 200. And I was like, man, I've never weighed 200. That's like a milestone, right? It's one of those numbers where you're like, shit, I've never been 200 pounds. Then I remember being 209, 210, thinking, okay, Sean, you've got to. So I got into it. I started working out again. I got down to 201 and I was like, okay, this is good. Back up to 210. Then I hit 218 and I got my blood drawn. Cholesterol, horrible. Blood pressure, horrible. Migraines, horrible. All the inflammation markers in my body, homocysteine C-reactive protein, ESR, horrible. Liver enzymes, horrible. Now you get in the picture here. Sean was not a healthy guy. I was working hard. I was stressed, eating bad. I'm now 43 pounds heavier than I was when I was in the military, and it kind of snuck up on me over 20 years. And I have nobody to blame but myself because I was the one that did that. I was the one that became inactive. And I'm sharing this with you because I'm not perfect. And so what I did was I've got a lot of friends in the quote unquote, hate this word, biohacking world. So I just said, you know what? I got to change. I got 4 kids. I got to be around because who's going to pay for their stuff? No, actually, their mom makes more money than I do. But I want to be around, you know? Maybe I'll have a grandkid someday and I want to be around for that. So I went on a mission, started looking at all of the pieces of the puzzle from medications to nutrition, supplements, spiritual practices, energetic things, anything I could get my hands on. And I came up with my own program. And I founded a new organization called the Hormone Education and Research University, HER University. And the first program in HER University is going to be the culmination of all of my education on the topic. There's a 2-month, a 3-month, and a 6-month program where it's all inclusive: labs, physician visits, coaching, weekly coaching, 27 hours of me talking to you every week to tell you exactly what's going to happen that week on the nutrition plan. There's different plans. There's AIP, there's keto, there's vegetarian. There are all the labs are included. All the supplements are included. It's going to talk through you through elimination diets. We're going to talk about driving inflammation down in your body. I don't like the word detoxification, but let's just say there is going to be a section on detoxifying you, because as you lose weight, things in your fat cells like pesticides and makeups and all of the things that we use are going to need to come out. We're going to bind those and get rid of those in your body. We're also going to be looking in depth at hormones. All this stuff is going to be included in this program. In those individuals who want to, not in everybody, but in those that want to, we may add the semaglutides or the metformins. We can talk about berberine. We can talk about inositol and really bring you full circle. And I'm almost willing to say, while I'm not trying to hang on the weight loss piece of the program, I want to tell you that you will feel better. Your hormones are going to shift. Your dopamine's going to shift. You're going to sleep better. You're going to feel better and look better in clothes. I can tell you, I hated going to the store to buy clothes. I hated it because nothing ever freaking fit me. I didn't like looking at myself in the mirror. Matter of fact, if I walked by a mirror, I wouldn't even look at the mirror itself. When I'm down right now about 33 pounds, and I can tell you, I don't ever want to go back there again. And it's a fear. You know, one of the fears I have, and you can tell somebody that's been overweight in the past that has yo-yoed like me, we don't want to get rid of our bigger clothes because we always think we're going to go back. And that's fascinating to me. We don't trust in ourselves that we can make that change because it's hard. Food is an addiction. The problem is you have to eat. It's not like alcohol. You don't have to drink alcohol. It's hard to quit it. Yeah, I get that. But you don't have to drink like 1 drink a day. You have to eat. The food is always there. And in this country, the food is calorically dense and processed beyond reason and easy to get and cheap to get. Actually, the worse the food's for you, the easier it is probably to get. So I put together this program because I want to help women feel better, look better, be confident, be healthy, live longer. And as always, my 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 pronouns should be he, she, because I feel like I have a really developed feminine side because I'm around women a lot. And I do feel like while I can't tell you exactly what you're going through because I'm a male, I do feel like I'm about 95% of the way there. Not in having babies by any stretch of the imagination. And I don't even want to know what that feels like, but I've seen it about 4,000 times. So I know it hurts. But with this weight loss part, I've been there many, many times. And what I did to really change my mind was I just hired a neurolinguistic programming coach to help me change the way that I talk to myself. And a good rule of thumb, and I'm going to close with this. I try to talk to myself now, and I've been doing this for a long time, no, a couple days. I'm going to talk to myself the way I would talk to my children. If one of my kids was crushed or hurting or sad about something, I would be in love with them. I would hold them up. I would give them options. I would talk to them like they were the best person in the world. And you know what? I don't do that with myself. I would tell myself I'm fat or I'm a loser or I can't make good choices or I'm half assed or whatever it was. And in a week, this coach has kind of reframed the way that I talk to myself. And that's amazing to me because I just didn't even think about it that way. But why don't I talk to myself that way? And that's part of the coaching. So the coaches that I have in my program now are those type of coaches. They're there to help you reframe the way that you think about yourself. They're there to acknowledge you, and you're going to be talking to them, and they're going to be familiar with the program. They know what to do. They know how to get you motivated. It's also leverage. If you know you're going to check in with your coach, you're going to, do what you got to do. And you're also going to be there with me. So I wanted to give you a down and dirty on semaglutide. It's in the news a lot. It's an amazing medication if used the right way. I love you guys. I'm there with you on your journey, and I hope to talk to you soon. Stay in touch.